Hello, and welcome to a Health Podyssey. I'm your host, Rob Lott. It's hard out there for a rural hospital in America. They serve a patient population that experiences disproportionately high burdens of chronic disease and mortality. And yet, despite playing such a vital role in the health of their communities, rural hospitals continue to struggle. It's hard to hire clinicians and other staff. Operational costs are high and patient volumes are low. And when it comes to the most needed kinds of care, chronic disease management, maternity care, geriatric care, the margins are incredibly tight, if there's any margin at all. And so rural hospitals continue to close. Too often, the finances and the math underpinning them, they just don't work out in favor of continued operation. And so what can we do about it? That's the subject of today's Health Podyssey. I'm here with Dr. Paula Chatterjee, an assistant professor of medicine at the Perelman School of Medicine and director of health equity research at the Leonard Davis Institute of Health Economics. She and her co-authors have a paper in the July issue of Health Affairs titled, quote, Mixed Evidence That Rural Hospitals' Finances Improved with Participation in the Pennsylvania Rural Health Model. I can't wait to hear all about its findings and to learn all about the work's potential lessons for rural communities nationwide. Dr. Paula Chatterjee, welcome to the podcast.
Thank you so much for having me.
So let's just jump right in here, maybe with some context. Can you tell us a little bit about sort of the state of rural healthcare in Pennsylvania before this program started? I know I kind of provided a really broad overview of rural hospital finances generally. How's the experience in Pennsylvania compared to that bigger picture?
Sure. So let's jump in our time machine back to the Commonwealth of Pennsylvania in, let's say, the early 2010s. That's really sort of the eve of the global budget demonstration in the state. And so at that time, I think what we can say is that about a third of Pennsylvania's population lives in rural areas. That amounts to around 3.5 million people who live across around 8 million acres. These are calculations that come from the Pennsylvania Office of Rural Health. So it's a big space for this 3.5 million people. In terms of their demographics, in a lot of ways, it mirrored what else was going on in rural America at the time. So about 20% of the rural population in Pennsylvania was under age 18. About 30% were baby boomers. Another 20% were in the 65 plus group. So we sort of see the typical demographics that we'd expect. This is a population that is disproportionately older. One of the things that, I think is always salient to me is that since around 1970, rural Pennsylvania's per capita income gap, when you compare it to urban areas, has doubled. And so sort of, to me, that really serves as testament to some of the entrenchment of poverty in these areas and how long that's been an issue. I'll say half of rural Pennsylvanians around that time were employed in the manufacturing industry, wholesale, retail, healthcare and social services were really emerging as sort of growing parts of the economy there. And so that's really sort of a snapshot of the people. If you want to hone in a little bit on the healthcare infrastructure, what I'll say is that some of the major health-related issues, on the eve of the global budget demonstration were really similar to what they are today. They included, poor access to mental health services. They include alcohol-related automobile deaths. They include an unfortunately high prevalence of abuse and neglect of older adults. And again, those are not necessarily unique features across rural populations in general, but are important in the Pennsylvania context. If we hone in on healthcare delivery, I'll say that around this time, there were estimates that rural Pennsylvania had one doctor for every about 600 rural residents. And they were suffering from some of the same challenges to retaining a viable healthcare workforce and infrastructure that continue to plague us all today. It was the cost of technology, high wages, the cost of obtaining highly educated workers. All of that was related to sort of this workforce challenge. And hospitals at that time, as they are, today in a lot of ways were particularly reliant on public payers, right? They were reliant on Medicare, reliant on medical assistance, which is our Medicaid program. And that combined with the high costs of an older adult population was enough to put a lot of financial strain on providers. And so if you want to look at sort of hard numbers on hospital closures in rural Pennsylvania in the pre-global budget model time, there are about 3 salient closures or conversions that happened. There was one in 2006, another one in 2012, and then a conversion in 2014. Those are data from the wonderful Shep Center that I know so many of us are grateful to for collecting these data. So I hope that gives at least a little bit of a snapshot of what we're talking about here.
That's great. And one point of clarification, when you describe a conversion, what's happening there?
A conversion can be defined kind of widely. So sometimes conversions mean that the hospital is shutting down inpatient operations and really sort of operating as a freestanding ED. Sometimes they're preserving other service lines. It usually implies some downgrade of service capability, but it can differ sort of depending on the place or the time.
Okay, great. So against this backdrop, you studied the Pennsylvania Rural Health Model, which I know you've already described briefly as a global budget. Can you tell us a little bit more about how that works and how specifically this model was implemented?
Sure. So the Pennsylvania Rural Health Model, or PARHM, I'm going to call it PARM, like, chicken parm, for the purpose of our conversation.
I love a good chicken parm. So.
Who doesn't? Who doesn't? So PARM was introduced by CMMI back in 2017. We're talking that's a time when we're a couple of years into the ACA, but really noticing that rural hospitals are struggling in unique ways outside of coverage challenges. And the way I like to think about PARM is that it was trying to test a theory, right? The theory was that if you could provide rural hospitals with a predictable source of financing, i.e. a global budget, then maybe you would give them the stability that they need to transform their care delivery models to increase access, improve quality, improve health, and, ultimately as part of the program to reduce growth in expenditures across payers. And really the sort of combined, the hope was that this global budget would be a linchpin in the strategy for sort of keeping rural Pennsylvania hospitals open. And so again, a lot of what I see PARM as being about was relying on this financial predictability piece, because it's otherwise just really hard to ask rural hospitals to surmount like these Herculean challenges in front of them, right? We're asking these hospitals to meet an increasingly complex and expensive, nature of care for an aging population while relying on public payers, though, of course, as we all know, Medicare Advantage was growing over the same time that this program was being introduced. We ask these hospitals to meet this challenge in a world where single digit differences in their censuses can have tremendous volume-based consequences for their finances. And so this pesky denominator issue really rears its head in every dimension. And that makes it hard for them to do big things. It's hard to do big things in an unpredictable world for these hospitals. And so PARM was trying to solve that part of the problem with the global budget. It was, trying to give them this predictable source of financing. I'm happy to go into some of the details if that's helpful, but I'm also happy to pause.
Yeah, thank you. Maybe give us the 2-minute version of how a global budget typically works. My understanding is that they, exactly as you described it, there's a predictable payment. And I guess some questions are, what is that payment based on? And, how might it vary from year to year? How is that implemented?
For each hospital that voluntarily wanted to participate in PARM, they would have a global revenue budget that was specific to each payer. So that includes Medicare, Medicaid, and commercial insurers that were participating in the state, of which there were a good number. The global budgets were indexed to historic revenue, and then they would make adjustments to account for different market dynamics from year to year. So that's one way in which you could expect some changes from year to year. The purpose of the budget was really to cover all hospital-based inpatient and outpatient care. It did not include things like physician payment, for example. And if you were a critical access hospital, for example, which already sort of operates under its own financing mechanisms, but let's say you also wanted to participate in PARM, you certainly could. And in those cases, the cost-based reimbursement continues, but they sort of try and make it a little bit more predictable by keeping payment amounts equal and consistent throughout the year. Again, trying to enable this world of improved cash flow and trying to avoid some of these periodic cash shortfalls. So again, all in the service of that predictability.
Okay, great. Well, then let's just dive in. Can you tell us a little bit about the outcomes you studied in your research paper and what you found?
For sure. So our paper was trying to understand what we like to call the quote unquote first stage of PARM, right? We're trying to see if hospitals that chose to participate in the program had financial improvements, because if they had those improvements, then that would allow them to be successful in sort of what we consider to be the second stage, which is then allowing them to transform their care delivery to meet the needs of patients in really innovative ways that sort of, fire on all cylinders. So that's why we focus on finances in this paper. We chose 4 financial measures to try and get at different aspects of a hospital's financial well-being. So we chose 2 measures of margins, which again are trying to give us like a global financial picture. One of those margin measures was focused on revenue that's specific to patient care. The other measure of margins was focusing on sort of more global, like broader sources of revenue. We also looked at a measure of uncompensated care provided by a hospital. And the reason we looked at that is because it's a measure of financial strain for a lot of hospitals. They have strong incentives to keep this number low. And then we looked at a measure of something called the current ratio, which is kind of like a measure of hospital liquidity. The nitty gritty is that it's taking sort of a measure of assets to liabilities over the course of a year. And it's trying to give us a little bit of information about trajectory, about financial trajectory for that hospital. And so combined, we were hoping that these 4 measures might tell us a little bit about the global financial picture for these hospitals that participated in PARM. So that's what we chose to measure. It's hard. One of the things I'll say is that whenever you're talking about small groups, it can be hard to draw statistical conclusions. And so here we're talking about 17 hospitals that were participating in PARM compared to 40 non-participating hospitals in Pennsylvania for which we had full data in our period. It's just hard. But we didn't want those small numbers to stop us from trying to pursue a rigorous analysis here. And what I was really excited about in this paper is that we are lucky that relatively new statistical approaches have caught up to this analytical challenge. And so I promise I won't, torture our listeners with too many details. But what I will say is I'll say that in 2022, some, really smart people came up with a new estimator that really allows us to apply a difference in differences framework to small sample sizes and still uphold the validity of all the statistical assumptions you need to make to ensure that this type of analysis is responsible. So again, not going to go into the nitty gritty. I fear I've already done so too much, but I think it's important to say, go ahead.
No, I was going to say this is super helpful context, especially when we're looking at sort of such I don't want to say narrow, but small, starting point. And so, so glad you kind of had those tools at your disposal. What did you find?
So what we found is that participation in the Pennsylvania Rural Health Model was associated with a 4.5 percentage point differential increase in operating margins and a 4.7 percentage point increase in total margins. However, what I will say is that those results became non-statistically significant once you started adjusting for some other components. And when we looked at some of the other measures of hospital finances, things like uncompensated care, that measure of liquidity, we actually didn't find any significant differences between the hospitals that participated in PARM and those that didn't. And so for that reason, we sort of conclude by saying this is a little bit of mixed evidence. In some of the models, we see improvements. In other models, we don't. And that's really trying to apply some of the state-of-the-art approaches that we have to this hard question.
Wonderful. I want to look under the hood of those results with you in just a minute. But first, we'll take a quick break. And we're back. I'm here with Dr. Paula Chatterjee talking about the Pennsylvania Rural Health Model. So just a minute ago, you shared that the results were mixed. Were you able to kind of look below that surface level and maybe identify some findings that that you want to look into further, or that might sort of be the starting point for policy discussions?
For sure. We tried to look at this question in a bunch of different ways and really tried to kick the tires through a lot of different statistical approaches. We can get into the details, but this was obviously a murky time to be evaluating a payment program. There was the small issue of the pandemic, which happened to be smack dab right in the middle of the implementation of this program, and so we try to look a little bit into how different features of the pandemic might have been at play with this payment program, and I think there are a lot of interesting questions there because we're lucky to be able to talk to some of the folks who are participating in this program, and it's fascinating what implementation has looked like on the ground for a lot of these hospitals. Some hospitals began participating in the global budget and were able to set up community health worker programs to try and meet patients at in different areas. Others have been trying to invest in different telemedicine capabilities. And so I think our paper sort of gives us that 30,000 foot view a little bit. And we're really excited to sort of dive in a little bit further and figure out what exactly has been going on the ground in terms of deploying these resources to meet the needs of patients.
Great. I'm curious about those conversations with the folks on the ground. What's the most surprising thing you heard from them in those conversations?
I perhaps it shouldn't be surprising to me at all, but I think that, in discussing some of these findings with folks on the ground, maybe I'll take a step back for a sec. CMS has mentioned that the first couple years of PARM, when they were deciding the allocations of the budget, there were concerns that some of them may have actually been overestimates of budgets. And that may have been just due to some details in accounting. And what I'll say is that even upon receiving, what some might consider were overestimates, a lot of these rural hospital leaders were saying, it's going to take a lot for us to feel financially stable, right? These are folks who have been dealing with financial volatility for decades in many cases. And while there's a lot, while I think that the principle of the global budget is really to achieve that stability on a shorter term, you're asking hospital leaders to view this program with a much longer lens and history. And so I think that, for me, that just gives more fuel to the fire to understand what are the specific challenges, which of those challenges can be met with a global budget, which can't. And so for me, again, it perhaps shouldn't have been surprising, but I think viewing it in the lens of some of these longstanding challenges was a really informative thing for me to learn.
So that's a great segue, I think, for my next question, which is to ask about how this piece, or the piece that is this program, fits in with many other programs and payments aimed at supporting rural healthcare, things like the critical access hospital designation, rural emergency hospital program, for example, as well as all those programs that aren't necessarily targeted at rural communities, but which rural communities depend on. 340B, the higher Medicare rates for hospital outpatient procedures. All of those things that have helped in a way over the years boost revenue for rural hospitals. How do you see PARM kind of fitting in that ecosystem?
I think I see PARM as part of that suite of programs that is trying to get at different drivers of these financial challenges for rural hospitals, right? Like I mentioned, PARM is trying to get at this issue of volatility through prospective, predictable funding. I see the other programs as trying to address similar, but still a little bit distinct aspects of the financial challenge, right? I see the critical access hospital as an effort to increase resources for small, geographically isolated hospitals based on, how it was originally motivated in the 1997 Balanced Budget Act. And it does this through cost-based reimbursement, but it remains a volume-dependent program and is not prospective like a global budget. There's other programs, right? There's the low volume adjustment hospital program, which is from CMS as well. And that's trying to get at the volume related challenge. And it gives you a payment adjustment that is commensurate to the volume related challenges. I see the rural emergency hospital program, which is sort of a newer kid on the block, is trying to address the issue of high fixed costs for a lot of these rural hospitals. We're saying, hey, it's okay for you to power down some of those inpatient operations. We understand that that's expensive for you, but let's keep other services robust and available. And so I think I think of 340B and DISH and some of these other financial sources in a little bit of a separate bucket. Again, addressing financial challenges, but perhaps a little bit more broadly generalized across the, outside of the rural context, but of course, very much instrumental for these hospitals. But I think, after I go through this alphabet soup, I'll say that I think all of this together sometimes points me in a particular direction, which is that we've come up with a lot of approaches to try and get at the challenges of rural hospitals, but they're still struggling. And I think that has made me want to think a little bit more about upstream policy intervention and what that might look like beyond the world of hospital payment.
So that makes me think of a paper that we published in the May issue of Health Affairs by Caitlin Carroll at the University of Minnesota and her colleagues that looked at the prices at rural hospitals when other nearby hospitals close. No surprise, prices go up when that happens for the surviving hospitals. And we had Dr. Carroll on this podcast a few weeks ago. We talked about sort of the alphabet soup, the crazy quilt of policies. And I asked her if she felt like they were working. And she, in a classic academic response, said yes and no. No shade there. But she said basically they're working because they're keeping many rural hospitals from closing. But they're not working because many rural hospitals are still closing. And one of the theories she offered for that disconnect was that the policies just aren't targeted well enough. And so I guess my question for you, do you agree with that sentiment? How would you sort of respond to this dynamic? And then two, how would you assess PARM in terms of how well targeted it is?
So for starters, just good life advice to agree with Dr. Caitlin Carroll, whose work I love and admire in this area. I think, let me be a little specific about that. I think I agree with Caitlin in that these policies work for some hospitals and they don't for others. And I think there's a couple of reasons for this, right? Part of this is just because rural America is beautifully heterogeneous and has different challenges. And the existing policy solutions we have address some, but not others. Another point I think that Caitlin makes beautifully is this issue about fit, right? Like I find this line of argument to actually be consistent with what folks in community health centers have told me recently, right? In their case, what's happening with them is they're being presented with like an array of value-based payment programs, but they have little idea on how to choose between them. It's hard for them to know ex ante which ones are going to be advantageous and which ones are going to introduce undue risk or complications of participating. They agree with the general sentiment of what those policies are trying to achieve, but it's really hard to pick what the best fit is. For rural hospitals, I think the fit is not clear because the financial landscape of rural healthcare is just changing really fast under their feet, right? Whether it's acquisitions by bigger health systems, opportunities to, engage with capital through private equity or growth in Medicare Advantage, right? It's hard to pick a financial strategy when the crystal ball is so murky. More broadly, I'll say that I think asking rural hospitals to assume upside or downside risk is just going to be a big ask, right? They already have an absurd set of challenges they're trying to navigate, and additional uncertainty is just like not desirable, right? Even if it offers the opportunity for financial stability, like in PARM, right? Hospital leaders were still concerned about the uncertain. What if payers change their mind about budget calculations? What if there are new benchmarks? What if a new financial threat presents itself like a pandemic, right? These are reasonable concerns. And I think that's why we saw sort of, a small number of participants in PARM, despite the intention to try and get as many rural hospitals involved. Whether that means it's a good fit for them or not, I'm not quite sure. We do know that some hospitals that participated did feel like they were able to weather the pandemic a little bit better than others, but that's just one dimension of fit. I think we'd hear a different story if we talked to every hospital.
Sure. Before we wrap up, let's take a step back and maybe I'd love to hear your thoughts for our listeners thinking about where we go from here. What do you think is the next step on this front when it comes to policy? And if your paper were to maybe inspire any sort of concrete or specific policy changes or improvements, what would you hope that to be?
So, Can I give two answers?
Absolutely.
The reason there's two is one is at like the 3,000 foot level and the other one is at 30,000 feet. So my 3,000 foot takeaway is that global budgets might still be a very useful tool for rural hospitals, right? There's another way to frame our results is that despite the tumultuous period in which PARM was introduced, participating hospitals did not take a financial hit, right? And that is valuable and important, especially for a lot of rural hospitals that see financial losses from year after year, right? I think that trying global budgets in a state without rate setting like Pennsylvania, in contrast to some place like Maryland, is valuable because you can see how a global budget works in the wild, right? And as we know, global budgets are only, going to become more prominent. They're included in the AHEAD model, and sort of continuing to follow the trajectory of this program, I think, is going to be important and interesting. My 30,000 foot takeaway goes back a little bit to the earlier discussion, which is that there's actually been quite a bit of policy attention on rural hospitals for the past several decades, right? There's been a lot of programming designed to support them and address the challenges that they find themselves in. But despite that, they're still struggling, right? Rural health outcomes are still suffering. And I think that juxtaposition of facts demands us to just pause for a second and ask why. Why are all of these well-intentioned policies not making big dents in this problem? And I think the way I find myself thinking about this these days is that when you talk to rural hospital leaders, they'll tell you about their financial challenges, but they'll actually spend most of their time talking about their patients and their workers, right? They'll tell you about how the burden of disease has just grown so dramatically and how it's harder and harder to keep highly educated labor in rural areas to sustain the hospital, and how their communities have been struggling for so long that people leave, and that reduces the tax base that's available to try and keep the hospital open. And so I find myself trying to take those observations and fit them into what we know about payment. And I think where that leads me these days is I think just focusing on payment is going to continue to be an incomplete solution. It's a very attractive place to focus as a admitted health services researcher because we can control parts of it, right? And because the stakeholders are confined to the healthcare industry, we can try and frame this as a healthcare problem. But I think improving health in rural areas is going to require investing in rural communities in a much broader way, right? Like only then do you have a population for the hospital to serve. Only then can you keep clinicians there to support these hospitals. By just focusing on payment, I worry that we're using a bucket to empty the ocean. And so my 30,000 foot, view these days is that I'm wondering if there's a way for us to think about rural health policies that are coupled to community investments for rural people, right? I think we need to sustain economic opportunities in these areas, expand broadband, attract businesses and infrastructure to these communities for payment policy to have a chance at being fully effective and realizing the potential that we want for it. And so I think that's sort of the direction that I find myself wanting to start thinking about this problem.
Great. Well, that's probably a good spot for us to wrap up. A wonderful way to think about it looking forward. Dr. Paula Chatterjee, thank you so much for joining us on the podcast.
Thank you so much for the conversation.
To our listeners, if you enjoyed this episode, subscribe, recommend it to a friend, leave a review, and tune in next week. Thank you.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about the Health Podyssey.